Okay, hi everyone. I'm going to go ahead and get started just in the interest of hoping to finish on time. If you can't hear me well, please just put a message in the chat box and I'll try to adjust whatever I need to. I'm Melissa. I'm one of the pediatric endocrinologists here. Thank you guys for wanting to spend your lunch with me today to talk about some thyroid testing. I chose this topic because I think it's very important that primary care providers really understand thyroid tests and when to refer and when not to refer. And there's a lot of interesting information out there on the internet that patients get a hold of regarding the thyroid, and being able to discuss this with them can help us increase their understanding a good bit. I have nothing to disclose. So today I hope you all brought a little bit of caffeine or have had some coffee this morning. I do want to review some basic physiology of thyroid hormone synthesis, as well as the different types of thyroid tests, just because I think if you understand that, you'll be able to discuss them a little better. And then we're going to interpret what results look like depending upon your patient's picture, and discuss what tests are appropriate to use in the general pediatric setting for screening and when to refer to us. So some basic thyroid physiology. The hypothalamus in the brain secretes thyrotropin-releasing hormone, or TRH, that stimulates your anterior pituitary gland to secrete TSH, thyroid-stimulating hormone. This then stimulates the production and release of both thyroxine, which is T4, and triiodothyronine, which is T3, from the thyroid gland itself. In the periphery, so in the body, the T4 is converted to T3 to become active. The T4 to T3 conversion is what provides negative feedback at both the hypothalamus and the anterior pituitary to decrease TRH and thus TSH production. It's also important to note that there are some other factors that affect your TSH secretion. Dopamine, somatostatin, steroid medications, illness, inflammation, and stress are particularly important, and we'll talk about that later. So how is thyroid hormone made? It's kind of a complicated slide, but just to break it down a little bit, thyroglobulin is produced by the thyroid follicular cell. It's made in the endoplasmic reticulum and is secreted into the colloid of the thyroid gland. Also, on the surface of the follicular cell, there is a sodium iodine symporter that pumps iodide actively into the cell. The iodide enters the lumen of the cell. There's a transporter protein called pendrin, not important for the purposes of this talk, but it brings the iodine into the cell. The iodide is oxidized into iodine by an enzyme called thyroid peroxidase, which will become important later in the talk as well. The iodine is very reactive, and it iodinates the thyroglobulin at all of the tyrosyl residues on the protein chain. This is a process called conjugation. As those residues are paired together, the thyroglobulin re-enters the follicular cell from the colloid, and then various proteases, enzymes liberate or remove the thyroxine, the T4, and the T3 from the thyroglobulin molecule. And then T4 and T3 are secreted by the cell through the MCT8 transporter. Now, what's important to take away from this slide is that most of the thyroid hormone release is as T4, which is actually inactive. Only about 20% of it is in the form of T3, which is an active form of the hormone. What happens in the periphery? Most of your T4 that's secreted is going to be protein bound. So only 0.02% of your T4 is free or not protein bound. Most of your T3 is also protein bound, just to a lesser extent. Most of the thyroid binding protein is going to be thyroglobulin made by the thyroid gland. A little bit of it is bound to transthyretin and some to albumin, and very tiny negligible amount to some lipoproteins. So thyroglobulin is going to be the main binding protein that we think about. The ratio of free T4 to free T3 in the blood is about 4:1. And that's due to the higher amount of T4 that is secreted. So there's higher circulating levels of free T4 to free T3, even though T4 is more tightly bound to its binding proteins. T3 then enters the cell. It activates thyroid receptors in the nucleus, and the remainder of the T3 is then inactivated to T2, or it's bound to cytoplasmic binding protein. T4 enters the cell, and it has to be activated before it can have an effect. So it's deiodinated by a D1 or D2 enzyme. They remove the outer ring of iodine from the molecule, which changes it from T4 to T3, and then T3 is active. Or it can be deiodinated by a D3 type enzyme, which removes the inner ring to form something called reverse T3 or RT3. This is inactive. So whereas T3 is active, if the opposite side of the molecule, if that iodine ring is removed, then it's RT3 or reverse T3, which is an inactive molecule. So what does thyroid hormone do in our body? So it has a lot of effects. Almost every cell in the body, or all tissue types, express thyroid hormone receptors. So it depends on the type of tissue its effect. In your skeletal muscle, liver, kidney, and intestine, its job is to increase oxygen consumption, increase metabolism. So it's responsible for maintaining your basal metabolic rate. In the liver, it regulates your cholesterol synthesis and metabolism. It also stimulates gluconeogenesis. In fat tissue, it stimulates the breakdown of fat tissue and also adaptive thermogenesis. So there's a role of body temperature. It increases your cardiac output, increases your heart rate. There's increased glucose uptake by your skeletal muscle. It also promotes muscle catabolism, and in children, it's going to stimulate skeletal growth. In the brain, it regulates brain development and growth in children, which is why it's so important that babies have a newborn state screen that includes thyroid testing on it. And in the intestine, it also regulates small bowel maturation and gut motility, which is why we ask about constipation being a symptom of hypothyroidism due to decreased gut motility. In the skin, it regulates your keratin and sebaceous gland expression, which is why you can get significantly dry skin and profound hypothyroidism, as well as some hair loss. Okay. So how do we test the thyroid? You can see there's a pretty long list of tests that are available to evaluate the thyroid gland. It can make you have a reaction of your head exploding when you're trying to choose what to use and how to interpret it. There's a lot of commercial so-called thyroid panels out there that include a mismatch of these different tests, and it's hard to know which one you should use. So I hope by the end of this, we'll be able to pick out the most sensitive test that you should order as a primary care physician to screen these patients. So we're going to go through this list briefly so we understand what the different tests are. First, I just want to review types of immunoassays so that when I'm explaining the different tests, it makes sense, hopefully, what I'm saying. So when we are thinking of labs and measuring hormone levels in the body, previously this was done by what's called a competitive immunoassay. That's a single-step test. Capture antibodies are anchored to a solid phase in a test tube. The certain concentration of a labeled analyte, this is a pre-prepared analyte, is added to the test tube along with the blood sample from your patient. Both the hormone and the labeled analyte compete for binding sites on the capture antibodies. So you can see the little green dots are the hormone from your patient's blood, and the gray ones are the labeled antigen. So basically the sample is rinsed, and both the unbound hormone and labeled analytes are rinsed off, and the remaining signal of the bound labeled analyte, so the little green dots, is measured. So this is somewhat reversed. So the higher the concentration of the hormone, the less the analyte will be bound, so there'll be less signal. So in other words, the weaker the signal, the more endogenous hormone is present in the blood sample, and vice versa. So the signal strength is inversely proportional to the hormone concentration. Typically, we're not using competitive immunoassays anymore. All of the tests I'm going to review, with the exception of two, are non-competitive sandwich type assays. These are just newer generation, more sensitive tests. In a sandwich assay, it is non-competitive in that the capture antibodies that are anchored to the tube, just like in the other type, then the sample containing the hormone as well as a signal antibody is added. So the hormone will bind to the capture antibody on one end and the signal antibody on the other end. So it forms basically a sandwich between antibody, hormone, antibody. The unbound signal antibodies are washed away and the signal from the sandwiches are measured. So the higher concentration of the hormone, which is in green on your slide, the more sandwiches there will be. So the higher the signal, the higher the amount of hormone. It's a little bit easier to interpret. Stronger the signal, the more of the hormone is present in the sample and vice versa. So sandwich assays, there are several types. They all use the basic method that I just talked about with complementary antibody pairs that capture and detect the analyte. There is radioisotype detection, which is the oldest form. ELISA, which we've all heard of, which is actually just measuring that amount of color change in the substrate, or immunochemical or fluorescent detection. As far as sensitivity, your ICMA and IFMA, so your chemiluminescent and fluorescent studies are going to be your most sensitive. Those are your newer generation tests, followed by ELISA, then radioisotype. All of these, however, all forms of sandwich assays are much more sensitive than your competitive assay that we talked about. Limitations to these tests are going to be interference from other substances, whether it's heterophile antibodies or autoantibodies in the patient's blood. So you do have to interpret these with caution. I also want to briefly talk about the hook effect. We think about this typically when we're measuring prolactin, but we also can see it with TSH as well. The hook effect occurs when there's very, very high hormone levels. And when this happens on the, you see on the side of the screen just shows what is supposed to happen with a typical sandwich assay, where sandwiches are formed between the capture antibody and the labeled antibody. When there's an exceedingly high number, the hormone is going to capture both the capture antibody and the signal antibody. And so it basically binds to everything in the tube. But because it does this, it's unable to form the sandwiches. So the decreased number of sandwiches are detective. So even though there's an exceedingly high level of hormone in the sample, you get a falsely low result because it's not detecting the so-called sandwiches. To be able to resolve this, you can perform the sample with serial dilutions, and that will enable the sample to form the sandwiches, and you can better interpret the results. So let's talk about TSH. This is the most sensitive thyroid test. This is the one that overwhelmingly you're going to order first, and anytime you're thinking about screening a patient for thyroid disorder. It's a third generation chemiluminescent assay, so very sensitive. It's a sensitivity down to 0.01 milli-international unit per liter. There is a diurnal variability, as there is with several hormones. TSH is at its lowest point during the midday, can have up to a 50% change in its value. So it does somewhat matter what time you're checking this. There is a 32% inter-individual variability, which means that checking a TSH in a person one day to the next can have a 32% difference in value. This is not clinically significant, but it can be interpreted by patients as a significant change. It takes days to weeks for your TSH to reach steady state. So if it's been suppressed for whatever reason, which we'll talk about in a minute, it can take up to 2 months to really recover. So it's not very valuable to check TSH more frequently than every 6 to 8 weeks. You should definitely use the reference range by age provided by the lab, as TSH does vary throughout the lifespan. And this is a fairly affordable test, anywhere from $25 to $90, depending upon company used. Free T4 is probably the next most common test that you'll order. There are 2 types of free T4. There's direct equilibrium dialysis, or free T4 by dialysis, and then just an automated sandwich assay. The gold standard is the equilibrium dialysis, and this test is very, very sensitive, very good. It's a lengthy test. It involves dialyzing a sample for 18 hours across a membrane that separates the free T4 from the protein-bound T4, whereas the automated test is widely available. It's rapid turnaround, does not require as much manpower to run. The direct dialysis, the reason it's the gold standard is it's not affected by albumin or thyroid binding globulin levels. There's no antibody that can interfere with it because it's a direct test. It can be affected by heparin. So if you have a patient on heparin, you would want to interpret that with caution, but it is not affected by estrogen. So teenagers on birth control pills who can have abnormal free T4 levels, if you order it by direct dialysis, you will get a true result. It is a more expensive test as well. The automated test that we use all the time, it assumes your TBG and your albumin are normal. So if you have a patient such as a preemie infant that has low albumin or somebody with poor nutrition, you can have a falsely elevated level. Or if you have a patient on oral contraceptives or pregnant patients, they have increased circulating levels of TBG, and so they can have falsely low free T4 levels. So in that case, you would want to order it by equilibrium dialysis. Heterophile antibodies do interfere with this test as well, though it is more affordable. Total T4 is another ICMA. It measures T4 bound to proteins. So remember that over 99, almost 99% or over 99% of your T4 is bound. So it's going to measure your inactive bound T4. The results are highly affected by thyroid binding globulin levels, albumin levels, by severe illness, pregnancy. Oral estrogens also increase the TBG levels, so you can have a falsely high total T4. Really, this has limited use now that we have the newer generation, more specific free T4 assays, but we still do see a lot of these ordered in the community. T3 tests, we get a lot of referrals for these as well. As far as testing T3, remember T3 is your active form of thyroid hormone. It's going to be elevated in hyperthyroidism, so toxic goiter, Graves' disease. It can be normal and mild to moderate hypothyroidism, however, so it's not very useful when we're just evaluating or screening somebody for Hashimoto's or autoimmune thyroiditis. It can be low in severe illness or severe malnutrition. A free T3 is just not a very useful test. It can be very variable throughout the day. The levels can vary rapidly. The assays just aren't very reliable, and it's low in only about a third of patients with hypothyroidism. So you can have a normal free T3, but be pretty profoundly hypothyroid. It underestimates the true levels because of the non-specific absorption of free T3 to a protein matrix used in the test. So it's a little more costly and just not very reliable. So in general, we say don't order a free T3. Reverse T3. This is a test that's actually not a sandwich assay. It's a liquid chromatography mass spec test, but it is measuring the metabolically inactive deiodinated T4 metabolites. So we talked about how T4 can either be activated into T3 or it can be inactivated into reverse T3. This is elevated in non-thyroidal illness or just severe illness. We see it in our DKA patients as well. It's also a little bit elevated in newborns and those in prolonged fasting. So this is not terribly useful outside of the inpatient setting where you're concerned about non-thyroidal illness. If you have an abnormal TSH and you think it's due to a severe illness, it's something worth checking. T3 uptake is an indirect measure of the quantity of thyroxine binding protein, mostly TBG, but also prealbumin and albumin. You use it in conjunction with a total T4 result to calculate something called a free T4 index. This is really not very clinically useful when we have such sensitive TSH and free T4 testing. It's altered in patients who have nephrotic syndrome, TBG deficiency, are on seizure medications or steroid medications, pregnant patients, estrogen-exposed patients. It's just affected by too many clinical entities to be terribly useful, and so that's another one that I would recommend we just don't order. Other thyroid labs that aren't measuring so much thyroid function but can give us good information are thyroid globulin. This is an indicator of the presence of the thyroid tissue. So remember, this is made by the follicular cell itself. We use this in congenital hypothyroidism, thyroid cancer monitoring to judge how much active thyroid tissue there is. In thyrotoxicosis or Graves' disease and in thyroid cancers, your thyroglobulin can be elevated, whereas in a patient who has congenital hypothyroidism due to not having a thyroid or somebody that's had it removed, it'll be low. If you have somebody who's taking too much Synthroid on purpose, they will have a low thyroglobulin because they are suppressing their innate thyroid hormone production. Thyroglobulin antibodies can interfere with this test. So if you have a positive thyroglobulin antibody, you are really not able to interpret that. So you always want to order those two tests together. TBG is the most prevalent binding protein for thyroid hormone. It is a sandwich assay test. It's a protein made by the liver. It binds both active and inactive thyroid hormone. This is affected by liver disease, as you would imagine, since it's made by the liver. Also nephrotic syndrome, steroid therapy. There is a inherited TBG deficiency that can run in families. It's pretty harmless. They just make lower levels of TBG, but it will affect their total T4. And then again, patients on estrogen therapy, pregnancy, and in newborns will have higher levels of TBG. Thyroid antibodies. So these are ordered a lot, and a lot of patients feel that positive thyroid antibodies indicates thyroid disease, and that's not necessarily true. These are both very, very newer generation, good sensitive tests, but they're both sandwich assays. The TPO antibody used to be called antimicrosomal antibody, so you may see it reported that way in some places. It does not indicate thyroid function. It indicates the presence of autoimmunity to the thyroid gland or Hashimoto's thyroiditis. In 70 to 90% of patients with clinical hypothyroidism will have a positive TPO antibody, but about 3% of the general population who has no thyroid disease also has a positive TPO antibody. The thyroglobulin antibody is the less commonly seen, but about a little over 2/3 of your Hashimoto's patients will have it. Thyroglobulin antibody is also used, as I mentioned, in conjunction with a thyroglobulin level to monitor patients who have had thyroidectomy after thyroid cancer to monitor the presence of active thyroid tissue. May also hear of TRAB or TSI. Thyrotropin receptor antibody, or TRAB, is the same test as thyrotropin binding inhibitory immunoglobulin. So it depends on which institution you come from and what your EMR reports it as, but they are the same test. They are usually sandwich assays now, but they can be radioreceptor assays. The thing with the TRAB or the TBII is it measures both blocking and stimulating antibodies. So positive TRAB could be an antibody that's stimulating the thyroid gland or blocking it. In Graves' disease, transient neonatal hypothyroidism, and atrophic thyroiditis, we can see a positive TBII. It is positive in 90% of your Graves' disease patients, so it's a pretty sensitive and specific test for Graves' disease as well. As you can see, it's quite expensive. A TSI, or thyroid stimulating immunoglobulin, is a different type of test. It is not a sandwich assay. It is actually an in vitro bioassay where they measure the ability of the TSI to increase production of cyclic AMP and TS receptor expressing cell lines. So you can imagine this is a very intensive test. It takes longer to get a result and is also more expensive. It's positive in about 80 to 90% of Graves' disease. It's measuring the activity really of the thyroid gland. So if there are blocking antibodies, you will not have a positive TSI. A positive TSI is really useful in pregnancy because it can predict the incidence of neonatal Graves' disease. As you can see, it's very expensive. Another important note is the TRAB or the TBII is reported as a titer in units, whereas the TSI is reported as a percentage of activity. Both of these can be followed throughout the course of Graves' disease treatment to see how a patient is responding. How do we interpret the results of all of these tests that we have available? So this is the simplified version, okay? High TSH probably means hypothyroidism. Low TSH may mean hyperthyroidism. However, this is probably a more accurate slide to depict how you can interpret these tests. So you can see there's a lot of different diagnoses that can come from these, a lot of different results that you can get. So I find this slide handy to just sort of interpret the basic thyroid tests. Most commonly, what we see is a pattern of hypothyroidism with a high TSH and a low free T4 or T3. We can also see subclinical hypothyroidism where you have an elevated TSH but a normal thyroid hormone level itself. It's important to notice that non-thyroidal illness, or NTI, is present in several of these lists. So a very sick patient can have very confusing patterns of thyroid function testing. It's really important to note that obesity can cause an elevated TSH. We see a lot of kids who have high TSH, normal free T4, normal T3, due to their BMI. There's a direct correlation between BMI and TSH levels. So higher fat mass leads to mild TSH resistance. Higher levels of leptin due to the higher fat mass stimulates TSH release. Free T4 is really not associated with BMI. So it's not so much that the TSH is causing weight gain as people would think. It is that the mildly elevated TSH is actually a sequela rather than a cause of the patient's obesity. Non-thyroidal illness can cause very confusing patterns of TFTs. Renal failure, HIV, liver disease, even DKA can cause this. And it's basically a reaction to increased circulating inflammatory cytokines. Most commonly what we see is a low T3 and a high reverse T3. And that's due to the D1 and D2 enzymes are less active. You have increased activity of the D3 enzymes, so you're making more reverse T3 than you are active T3. The pattern of sick euthyroid syndrome or non-thyroidal illness can depend upon where they are in the phase of their illness. As you can see, the reverse T3 is typically high throughout until it resolves. The TSH can be confusing in that in early phase and the most severe phase of the illness, it's depressed, but as they recover, they can still have elevated RT3, but they can have a rebound elevated TSH. And so it's important to interpret those in the setting of your patient's clinical picture. Also, as we know, medications can affect TFTs. I won't kind of read through this for you, but the take-home message is to basically always review the medication list, particularly if they are on anti-epileptics or antipsychotics, as those medicines can affect the thyroid in multiple ways. Recently, there's been a lot of reports of patients taking biotin supplement for hair or skin or nail health, and this is very high dose biotin, but interferes with the sandwich assay because the antibody that they use in the sandwich assay is biotin based, and so what can happen is the biotin in the blood will bind to the antibody as well, and so you'll get a falsely high number of sandwiches, and it will appear as if the patient has an elevated free T4. So it's recommended that if your patient is on biotin, that they stop that at least 2 days before they have labs drawn. When do you check a TFT? In pediatrics, the most important time for us is when a patient is not growing, so short stature or linear growth failure. They have multiple clinical symptoms, and the symptoms of hypothyroidism are kind of nebulous, you know. A lot of kids are constipated, irregular menses, skin or hair changes, or new onset fatigue, although we know all teenagers are tired. If there's a strong family history, particularly on the maternal side of thyroid disease and symptoms, we recommend checking it. If they're taking any of those high-risk medications listed on the previous slides, or if you feel they have an enlarged or abnormal thyroid on physical exam. We do not recommend routine screening of thyroid function tests in obese children who have normal or accelerated linear growth, or in teens who are just complaining of fatigue in general. This is a flow chart I created just to help interpret the thyroid function testing. I recommend you start with the TSH as it's the most sensitive. In reality, we often order TSH and free T4 together, but if you're forced to choose one for some reason, I would choose the TSH, and then whether it's low, normal, high, that'll lead you down the algorithm of what to order next and when to refer to endocrinology. This is how a lot of people